Good morning to everyone here in person, to everyone online. So I'm Greg Roth. Welcome to UW Cardiology Grand Rounds. It's my great pleasure to introduce our Murray Visiting Professor in Cardiology, but I want to take just a moment to express my appreciation to Jack Murray, who's here, who's had a 60-year relationship as a faculty member and supporter of cardiology here at the University of Washington. So first, Jack, to you and your family, thanks so much. Thanks for being here. I'm delighted to be able to introduce Brahmajee Nallamothu, our visiting professor. I will keep this very short, Brahmajee. But he is professor of cardiology and medicine at the University of Michigan. He did his medical school training at Wayne State, and then I believe was a general cardiology fellow and interventional fellow at the University of Michigan, and has had just a remarkable career there. And I think many of you are probably familiar with him and his work. Beginning with sort of groundbreaking work in quality and outcomes around coronary angioplasty, myocardial infarction, and cardiac arrest, but it's gone well beyond that. He's, for a long time now, been editor-in-chief of Circulation Quality and Outcomes. A couple of the many roles that I found you have, and I'm sure I'm not covering all of them, include co-director for the University of Michigan Precision Health Initiative and co-director for their AI and digital health innovation program. So hopefully you can explain something to us about AI and all of the things we think about it today. He is an amazing research collaborator. He's had over 250 publications, well funded by NIH, AHA, and many other organizations. He's also, I would say, just an iconic mentor for generations of trainees and continues to be just a leading light for us in cardiology. So Brahmajee, thanks for being here. Really looking forward to your talk.
Well, thanks, Greg. It's wonderful to be here. I'm really excited to kind of share some ideas with you today. And I just wanted to start off also by just thanking Dr. Murray. It was a wonderful dinner last night, right on the water. To see like Mount Rainier on one side and the Olympic Mountains on the other. And I was just sharing how I've been to Seattle 4 times in my life and I've yet to see a cloudy day. So I think I've been very lucky and fortunate so far. I was gonna start with a type of different perspective. And what I like to start this type of talk with is really a story. And this story goes back to a social psychologist named Brian Nosek. And, Brian Nosek he's a faculty member at the University of Virginia. And a few years back, he was interested in a question. And the question was essentially, do soccer players who are darker skinned more likely to get red card than like lighter skinned soccer players? Now, I want to mention this for a couple of reasons. Red cards are important. You guys are going to find out. I think you guys are hosting some of the World Cup games in a couple of years here. But like red cards are very interesting because of 2 reasons. One is they're big penalties, right? Like if you get one, you actually get pulled off and your team cannot replace you. So you play short manned. The other thing about red cards is that they're really based on a couple things. First of all, the degree of the infraction, right? Like what actually happened. But the second is this measurement of intentionality, right? And so the referee has to decide, the official has to decide whether or not, what level of intent was made with that injury. So what's fascinating about this is that, on one hand, it can seem like it's like a little, playful example of a question, but I don't think it is really hard in 2025 to imagine the underlying relationship between this and so many different types of questions we ask, across all our different disciplines, including healthcare. So Nosek was like fascinated by this question. He said, I'm gonna do something, I'm gonna create this project around this. And he went through a great deal of effort, right? So he collected data on over 2,000 players, over like 3,000 referees from 4 major countries in Europe. He created lots of features around all these data, heights, weights, games played. He collected data on the referees themselves. And then he even went further, right? He scraped the web and he found about 1,500 photos. And he had them coded by two different reviewers on a scale of like very light skin to very dark skin, right? He really wanted to tackle this. And then he ended up, with these analytic file that had about 150,000 player referee dyads, right? Now, if I were going to tell you how this story traditionally ended, I would tell you he probably went back, found some postdocs, some doctoral students, right? They started to analyze the data, they found what they found, and depending on what they found, we start to learn about it through, again, whether it's Fox News or the New York Times, right? But actually, the interesting thing about it is that Nozick was not really interested in this particular question. What he was most interested in what you would think about this question. So he took this data that he had cleaned, put together, and he said, I'm going to actually crowdsource this data. So he has a pretty broad social network, and he started to recruit analytic teams, and he just said one question. He said, this is the only thing I want you to focus on. This question, are soccer referees more likely to give red cards to dark-skinned players than light-skinned players? And you can do whatever you want with that question and these data. And there were 77 teams he recruited. 33 of them ended up submitting proposals, and then 29 actually went through the whole analytic process. All right, so it's really important to understand that all the teams made their own analytic choices independent of the others, but they were able to view the other plans before finalizing. So what did he find? This paper, which was published a few years back, called Many Analysts, One Data Set, and this same type of experiment now has been replicated in a number of different situations. And I'm going to walk you through what their primary findings are. And this is a little bit of a complicated slide, so I'm going to organize this for you, right? So what you have here on this x-axis is all the different 29 research teams and their primary findings. And then you have that basic line about the line of equivalence, right? Equally likely. So the dots represent the main effect that they found, the association with whether or not red cards were more likely to go to darker skinned players. And then you have confidence intervals around each of these, right? So if you look at this, there's quite a spread of analytical results. And to summarize this, there's a handful of things. So first of all, the effect sizes that they measured went from 0.89 to 2.93. So a 10% lower likelihood that dark-skinned players would actually get red cards, all the way up to nearly a threefold higher risk. 20 of the studies found significant results by traditional statistical testing. 9 did not. And not unsurprisingly, the variation was explained by the analysts' choices in statistical modeling. All right, so I'm going to let you sit with this for a second, but I'm going to tell you what 3 people who I have tremendous respect for, what their opinions were when this study came out. The first is Nicholas Christakis. He's probably the most famous physician social scientist in the world today. And so Christakis wrote, very disturbing. 29 analytic teams tackle whether skin tone affects red cards in soccer and find that significant variation in results may be difficult to avoid. The second is somebody who's probably not going to be a stranger to this audience, Harlan Krumholtz. He's the editor-in-chief of JACC now. So Harlan wrote, this is one of the most important studies published this century. And then the final one is John Mandrola, again, very well-known electrophysiologist, physician blogger. And he wrote, rare is a study that forever changes your view. And I want you to kind of think and reflect on how you would think about this, because the reality is what happens mostly is that Nozick could have run any one of those analytical results, right? We could have known about none of them except for the one he chose to share, right? And again, depending on what he wanted to share, you could imagine something from it doesn't really matter to it is super important. And I think that uncertainty is something that's troubling, these 3 folks, but it's also something that I think we have to understand a little bit better at the core of science today. And that's kind of the basic of what I'm going to talk to you about. A lot of it is around cardiovascular examples and to share with you at least my evolution and education over the last few years. So the outline of what I'm going to talk about is really the problem of reproducible research. I'm going to talk about why it occurs and recent drivers. Then I'm going to end with potential lessons and some solutions as well. All right, so a lot of this is informed by my work, as Greg had mentioned, as an editor-in-chief of one of the Circulation daughter journals. I am the editor-in-chief of Circulation, Cardiovascular Quality and Outcomes. It's in the AHA family of journals. We publish about 80 or so research articles a year. We have this 10% acceptance rate. What I like to say about Circ is, we're definitely not the New England Journal, JAMA, Lancet. Thankfully, we're not at the bottom either. We're like snap dab in the middle tier of journals, which is actually a wonderful place to be because this is where most of us who do research are going to end up spending our careers. It gives us an opportunity to see kind of the good, the bad, and oftentimes actually even the ugly. And what this is kind of framed for me is a number of core issues. And one thing that I will say is, at its core is this idea that people have been talking about this for a long time, that does the published scientific literature produce too many false positive findings that are overstated and not reproducible? And then, the inefficiencies and waste that this might occur. And like I said, we have this, cover from like The Economist from just a few years back, but like this problem goes back, literally centuries. Charles Babbage complained about this in 1830, right? That we were doing inefficient, unproductive research. Now, as I'm saying this, I also want to make one thing very clear. I'm not trying to say this in a way to be sanctimonious, and I also don't want to say this in a way to say that there are good guys and bad guys, right? There is definitely fraud out there. There are definitely people who do things that are inappropriate. What I'm talking about is how do intentionally, people who with good intentions are trying to push the envelope of science further, how can they sometimes get into mistakes and errors over time? And I'm like number one poster child on this. And I look back, I don't know if you do, Greg, at some of the ways in which we did research just even 20, 25 years ago, and how we've evolved. And I think it's a good thing overall. So I'm going to just, start this with also this idea that, I told you this cute story about soccer, and people are always like, you know what, that's great. That's a wonderful little example, but that's not really happening in medicine, right? I mean, medicine, we talk about serious problems and we have serious solutions. And I'm just going to walk you through very quickly why I don't think that that's the case. So, I mean, you can even just start with, the fields of like health policy, right? So there's a hospital readmissions reduction program that's been around for a few years now. And there's this question about whether or not instituting this penalties to, hospitals that had excess rates of readmissions around heart failure and other conditions led to mortality differences. And, I could go and spend a whole talk on this alone, but I'm just going to share with you, this is the example of the field's, current status, right? We had 2 papers published about a year apart in JAMA that used the same data set, right? The CMS Medicare data set, and they came to like just completely different conclusions, right? The paper on the left suggested that there were significant reductions in in-hospital 30-day mortality rates after the institution of this program, whereas the paper on the right suggested that actually there were increases in 30-day post-discharge mortality. These are both great groups, right? One group is, Harlan Krumholtz's group out at Yale. The other group is like Bobby Ye's group out at the Smith Center at the Beth Israel. And what's just striking about this is like, we publish this stuff and nobody is like up in arms about the fact that like, how do 2 people come to completely different conclusions around this? Now, when people think about this, they say, well, it's health policy, Brahmajee, that's like one step away from like talking about soccer and red cards, right? I mean, pseudoscience, don't worry about it. But, you can go on and on, right? In epidemiology, there's this great example of bisphosphonates and the question about whether they lead to GI-related cancers. Same story, right? Like, within like months, there are two papers published, one in JAMA and then the other one in the BMJ, literally talking about the same question with the same data set and coming to disparate conclusions. And what's fascinating about this is, which one do you think is actually cited more? The one that says that there is a risk with cancer, or the one that says there is not a risk with cancer? What would you say, Greg?
I would, I would say that it is the one that says that there is not a risk of cancer.
No, the one that's other way, right? Right? Yeah. In fact, even though JAMA is a higher impact factor journal, that one showed that there was no risk, and that paper tends to be cited less. And it's not like there's a different time period, right? Like I said, these were both published months of each other. And if you look at them, they're actually cited differentially by different types of papers. All right. Again, epidemiology, let's talk about experimental evidence. This happens in RCTs, right? We have RCTs in MitraClip now that show that it might have benefit, others that don't show that it doesn't. And, we kind of understand this, right? Because there might just be a spectrum of real outcomes, how you select patients, how you bring them in. So again, there's ways in which we can talk around this. So then people talk about, okay, well, let's talk about the real science, right? Preclinical research, right? And I just want to bring up, this is such a remarkable space, but there's this wonderful piece by Glenn Begley and Lee Ellis who wrote this in Nature, and this dates back a few years ago. But, they wrote this so what happened was that at the time, at Amgen, they were trying to reproduce some of the results of famous experiments that were being published in Nature, right? And so they picked 53 papers that they said were landmark studies. And they tried to replicate these experiments independently because industry has a great interest in this, right? I mean, if they're going to devote, millions of dollars towards a new line of therapy, they need to know that it's actually meaningful. And what they found was they could only confirm in 6 cases the findings of the original papers, right? I mean, that's 11% of cases. And they end with this great line, even knowing the limitations of preclinical research, this was a shocking result. And this has actually been also replicated subsequent to this in other papers as well. All right, so I hope I've convinced you that there is this kind of unsettling feeling about reproducibility in research. I'm going to talk to you a little bit about why it occurs and maybe some recent drivers. So, there's this fascinating area of science called meta-science, and it essentially is using scientific methods to understand why we produce certain types of science results. So having science kind of, shed a light on itself. And, the Bible of this movement is probably this paper by John Ioannidis. It's one of the most cited papers of all time. It was published in PLOS, and it's titled "Why Most Published Research Findings Are False." And what he decided to do was he decided to actually create a simulation around papers that kind of come out and try to understand, what is driving this from a mathematical standpoint. And as part of this, he created this, this variable called mu, which is what he defined as the combination of design, data, analysis, and presentation factors that tend to produce research findings when they should not be produced. And what he found through this simulation was that, studies are less likely to be true. And, some of these are obvious, right? If the study is smaller, if the true effect size is smaller, and then if there are a greater number of relationship studies, so less discriminate selection of hypothesis and testing. But then he went on to say, the more flexibility you have in the design of a study, that actually causes, a lower likelihood of truth. The greater the financial and intellectual conflicts of interest that are apparent, and then the hotter the topic. And the question, though, remained kind of why. And what I'm going to walk you through is I think there are 3 major issues around this. Part of it is just the nature of how we explore ideas. So one is just statistical limitations. We have a limited ability for us to kind of think through when something is true and when something's not. And these are things that have been hundreds of years old in their understanding. And one of them is, just the tyranny of the p-value, right? We're so obsessed about this. The p-value ignores prior evidence. There have been lots of attempts to move towards more Bayesian thinking. And I'll talk with you a little bit about why the p-value, though, is held on. But it's important to remember that it's not how likely a hypothesis is to be true, but it's how surprised to be with the data you've collected if you assume no relationship exists. And the way that this manifests itself is if you have something like a toss-up question, a hypothesis you're truly equivalent about, and you have a 50-50 chance of thinking like, did this really happen, or is this association real or not? And you have a p-value of, let's say, 0.05, all you've done is nudge that to like from a 50% confidence to about a 71% confidence. If it's a p-value of 0.01, you bump that up quite a bit, right? Now, the good bet, right, when you are almost certain that this is already going to be true, a p-value that's like 0.05 or 0.01 really brings it up into certainty. And then the last thing is the long shot, right? Now, the long shot is the idea that you really don't know whether this is true or not, but you're just going to test it. And even if you have a p-value of 0.01, you've just basically brought that up from a 5% chance up to still a 30% chance. And the reason I think this is important is, as you'll see in other kinds of areas as I talk, I don't know if we live in the toss-up. I certainly don't think we're doing studies on things we already know exist, right, in relationships. I think much of science has moved towards trying to find and discover things kind of in this long shot area. And that brings up a lot of concerns as you start to think about the proliferation of research. So the second thing, besides just the statistical limitations of how we analyze data, is the questions around degrees of freedom, right? Research degrees of freedom. And it's important to go back to Nozick's experiment, right? Because researchers don't just conduct an experiment, they oftentimes conduct many experiments, especially as they're iterating with data. And there's definitely this potential for p-hacking, and it doesn't even have to be like intentional. It can be just subtle things, right? Like questions around, should I collect more data because it doesn't seem like it's making sense? Should some observations be excluded? We can always decide that somebody was an outlier for whatever reason. Which control variables should be considered and how should they be entered into models, right? It's remarkable when you actually work with data, like even those choices of, do you break up an age into just over 65 and under 65? Do you add it into a model linearly, or do you make more adjustments that need to be made? It's really fascinating how these things can also play a role. And at the end of the day, there's also this degree of freedom of reporting and publishing only what works. There are lots of times when you do a study, you expected something, and at the end of the day, you didn't really find anything. Who's going to spend the time and effort to write that up and then actually go through publishing when we all have like fixed time? And in fact, this has led to something called the file drawer problem, where what we see mostly are like positive results, and all the negative results are hidden away in each of our file drawers. There's a third thing I want to talk about, which is study design limitations overall. When you think about study design limitations, I'm just going to do a time check because it says, oh, great. Study design limitations. There's all sorts of things, right? In terms of data collection and outcomes measurements. Greg spoke a little bit about my background. More recently, as just an example, we are collecting data now on a lot of like digital health tools and wearables. And boy, it used to be like a large data set was like, I don't know, 10, 20,000 participants and maybe like 100 features on each of them. We're collecting data now to the point where there are like billion cells, right, in some of these estimates, because they're collecting like minute by minute data on heart rates in like hundreds, if not thousands of participants. And the amount of complexity and confusion that can happen with that is really startling. Like you really do need to know what you're doing. There's also this ongoing challenge of causal inference, right? I mean, we've always lived with this tension between observational and experimental data. I will say that like I have been humbled by how many times like we've thought an association carefully analyzed is real, and yet it gets overturned by an experimental RCT time and time again. There is a lot of movement in this space, and I think it's a good way of doing it because I think we at least understand those issues now, and we are trying to think through them. But like, this is a very important paper. This was written by, Kirsten Bibbins-Domingo, who's the JAMA editor, and as well as like a young up-and-coming scientist named Isa Dahabar. And both Isa and Kirsten are arguing that there are now new epidemiological tools where we can start to develop causal inference even with observational studies. And JAMA has been one of the journals that's been pushing this. But boy, the history of medicine is littered with associations that end up falling as we kind of advance over time. I think that there is a lot to be said in this, but I think that it is really one of those things that is going to always remain a big concern. And then I just want to point out, even ideal study designs are still vulnerable to the relevance of the question in population. And an example I always like to give is a tongue-in-cheek one, but we published this a few years back with Bobby Ye's group and the Smith Center. But there's always this famous example that's been given that parachutes have never been used or studied in a randomized clinical trial, and therefore, if you're a true fan of evidence-based medicine, you should not use parachutes. So we did this trial where we actually randomized patients to parachute use, when jumping from an aircraft, and we found that it did not reduce death or major traumatic injury when jumping, and it was largely because it depended on where the aircraft was located, right? These were all aircraft that were on the ground, but everything else, it was multi-center. We had different types of aircraft, all those other check boxes. And for people who laugh and say, wow, this is really tongue-in-cheek, if you look at why our literature on cardiac arrests and treatments have not improved in a lot of like RCTs over the last several years, it's not very different from this, right? Randomizing patients in the field with cardiac arrest, you either end up getting those patients who are so healthy that whatever you're doing is not going to make a difference, or they're so dead that whatever you're going to do is not going to make a difference. So picking that altitude of where these therapies work has great relevance, throughout many examples in medicine. All right, so what about the drivers in recent years? And I'm going to go through these a little bit quickly, but I just have to say, one of these is like the biggest issue is the wide availability of data and software tools, right? This is one of the great things about what's happened, but it's also kind of one of the limitations. And a wonderful example is like the nationwide inpatient sample, which is it's a nationwide data set that's collected, made freely available. As an editor, like we get at least a couple of these papers every month, right? Somebody has like downloaded this data set, asked some simple association questions, and kind of written it up. But the challenge with this is these data are collected very selectively, and they're collected oftentimes in a complex way, and you have to make sure that you analyze it correctly. And Rohan Kara did a wonderful study where he just went through all the papers that had been collected from this in recent years and just showed like just how many times simple errors happen, right? There were only a third of papers that were published, even in high-impact journals, without any errors in them, which was kind of striking to see. The other thing that's happening is coming is technology like ChatGPT and OpenAI. This is you can find YouTube videos on like, can ChatGPT write your next scientific paper? And it is remarkable how well these technologies are starting to take hold. This is a very famous, it's about 2 years old now, Nature survey, where they got 1,600 researchers just to talk about how they're using large language models and ChatGPT in their own research. And what they noted was, at that time, about a year and a half ago, 2 years ago, about 40% were using it in some capacity or not. Most of them were using it more to kind of play around. I would guarantee you this number is double now. And then the way in which they're using them, I think, has also shifted. what's interesting is how many people actually were concerned from the very beginning about how to use these generative AI tools as well. Their concerns with like, making plagiarism, harder to detect, bringing biases into literature searches, all sorts of problems around this. But this is causing just a flood of papers to come through. And there's a lot of evidence now that many of these are starting to make their way into the literature. There's also this just inflationary incentive to publish more and more. I mean, we all lived through it. We published a paper a couple of years ago where, there were 14 clinical trials of DOACs in the setting of like atrial fibrillation. So 14 randomized clinical trials. And at the time, these investigators were pointing out that there were nearly 60 meta-analyses of those 14 randomized clinical trials. Just pointing up we're just generating data to just generate data. And, it's the old adage of like, it seems sometimes like that scientific papers aren't even meant to be read, they're meant to be written, which is a concern, I think about a lot as an editor. And then this is just accelerating now that we have paper mills and predatory publishing. But at the core, I think it's really driven by the fact that our currency of realm in academic medicine continues to be peer-reviewed publications. And they're just under pressure more and more to kind of produce this type of science. It's something that's kind of come up a lot in many discussions. And then finally, I'm just going to mention this idea of hype cycle. This came up a little bit with Greg last night at dinner. I think we've changed the language around science in kind of ways that I find a little unsettling. Like we borrowed the Silicon Valley language, and now we use it in science to talk about moonshots, hacking health, one brave idea. And it's so fascinating, like that center picture there, right, with Mark Zuckerberg and Priscilla Chan. I mean, it's very generous that they're willing to give $3 billion to fight disease. But if you look at the back behind them, they have this quote there: "Can we cure all diseases in our children's lifetime?" As if we're just $3 billion short of curing all diseases in our children's lifetime, right? Like there's this idea that they just have to hack this problem and then everything will be really okay. And then, all of this kind of came to bear with the COVID-19 pandemic. And I always like to think of it as almost like a stress test for science. It was in many ways the best of what we were able to do as researchers, but it also raised so many issues, right? Everything that I had mentioned, right? The growth of data sources, there was an explosion of data. There were so many scandals and, retractions that occurred around this. It was also driven by this like incentive to publish more and more, with preprints and the dissemination of like, just science, all around. And then most of that, though, was this clutter of like low value science that just seemed not to bring much to it. And then obviously, the hype cycle was just a big part of this, especially as pandemic science seemed to mix with politics. And, one example that I've always found really fascinating about this is, COVID-19 and myocarditis for us as cardiologists, right? So if you guys remember, as soon as like COVID hit, there were some cardiac issues that were described in case reports of disease. And then there was in the summer of 2020, this really well-publicized study that was published in JAMA Cardiology. It was an MRI study in Europe of 100 patients who were recovering from COVID-19. And they reported that they found 78 of those patients had some abnormal results. And 60 of those even had ongoing inflammation. Now, I want you to just take a look at that article. Like if you look up at the top part of it, right? I mean, this article has been viewed over 1 million times, right? That's like ESPN.com numbers, not like, JAMA Cardiology numbers, right? And its altmetric score, just to put it in perspective, it was like one of the most highly visible articles of all time, right? So they published this, and there was a lot of concern, right? I can tell you that, like, even at Michigan, right, there was all this discussion because the football season was starting, and we were wondering, like, are we putting our athletes at risk. So there were some issues almost right away that were brought up about data concerns and irregularities, but it did not stop the season from starting, and even with concerns around it. So then what ended up happening was there's a follow-up study done, right, published just 6 months later. This was done out of the University of Wisconsin, where they did a much more careful, well-analyzed set of like student athletes, many more patients too, and they found that the risk of MRI abnormalities was much, much lower, right? But if you look at this, like it's been viewed 47,000 times, right, versus the million, and its altmetric score is 362 versus like 13,300. So better study, just 6 months apart, and just the dramatic amount of attention that it gets. All right, so I'm not going to leave you drowning. I think there are solutions to all of this, and I think that there's a way forward that I think we're just doing much, much better. So I'm going to tell you a little bit about potential lessons and solutions. And the first one I'm going to start with is one that I've definitely grown with in recent years, which is just having this baseline humility to start with. Science is hard, and I'm going to explain to you a little bit about why I think we need to appreciate this more as we kind of like evolve over time. So the first lesson is I think this is just so urgent. I think we do need to have a better framework for open science. And what do I mean by open science? It means transparency in methodology, observation, and data collection, public availability and reusability of data, and then also the more accessibility and transparency of scientific communication. And there's a great line from Michael Faraday, that a quote, when a young scientist asked him how could he succeed, he said, you got to work, you got to finish, you got to publish, and then you got to release, right? That's the new fourth word, right? Like you got to share what you're doing more openly. And there's no better example than this paper, which looked at mortality rates in Puerto Rico after Hurricane Maria a few years back. And what was brilliant about this paper was that at the time, there were all sorts of estimates, right? So if you look at this, the New York Times had estimated through their own analytics that about 1,000 people died. There were a couple of other independent groups that had assumed maybe about 1,200 or so. And then the Trump administration at that time had said there were about 64 people that died. And what these guys ended up doing was doing a very careful population-based sampling of the communities in Puerto Rico. And they found, much higher rates as point estimates, but you can see the degree of uncertainty that they represented. And I think that that's a very important piece of this. But what's most fascinating about this is on the date that they published this paper in the New England Journal, they released the full data and analyses. And they basically said to the entire community, like, look, you can have a real-time debate of these findings. And they said, these adjustments represent one simple way to account for biases, but we have made our data publicly available for additional analyses. And it turned out a lot of data sleuths went and into this, and these guys did a wonderful job. They very much justified their rationale about their assumptions, and in many ways, they represented the best of how to do that. We've tried to do this at CircCQO, where we've even tried to create the opportunity when you publish a paper that you can actually place your data in the precision medicine platform that exists at the AHA. So at the time of publication, you can have your data also available. But what's so humbling about all of this is you can do this, but until we change the culture around this, like no one will take you up on the offer. And then even if you do put your data out there, no one, it seems, really cares or will go at it. So it's not going to be easy to change a lot of the culture around this. All right, the second lesson is about pre-registration. I think this has had a dramatic effect on RCTs. Prior to pre-registration, nearly 60% of RCTs that were published from NHLBI-funded studies actually had positive results. And then after pre-registration, that turned out to be much lower, only about 8%. And it just shows you that naming what you're looking for right up front is very critical as a step towards all of this. I think we need to do this and expand this to epidemiology and observational studies as well. And there are groups that are starting to move towards this, which has been a great sign. And journals like The Lancet have actually been leading in this space for a while. I think we need to be very humble about accepting corrections in a better way. There's the very famous article a few years back on the Mediterranean diet. It turns out that this article was published in the New England Journal originally, but then there were some data irregularities that were noted about a decade or so after. And what happened was they ended up actually correcting, and it was a great example of like retracting their earlier study and republishing it. And, I really have to say that I have personally gone through this, with my own work, and it's been a very humbling experience, right? So we published a paper in my own journal, right, where months afterwards, right, it was published, we were trying to use the same method in another paper and analysis. And the PhD student who was working on it with us, sent an email. And I always am so impressed by like, the courage, because, this person had to send this email to me and say, actually, we found that what we had done in the other paper was incorrect. And she was very scared, very worried. And, it was one of those things, like a very open moment for me to realize like, wow, what do we do now with this, right? We obviously have to correct it. It was like, just all these sudden moments of like what you go through, right? You're very embarrassed. It's also, you don't want to punish this person, right? And you want it to be kind of a growth opportunity, but we don't have that kind of culture right now. And then the final thing is, like, I'm the editor of this own journal, and it took me like 9 months to even retract my own paper, right? Even despite me pushing this all along. So very time consuming too. The fourth thing is this idea of, really not accepting any easy answers. And what do I mean by that? I mean that, many changes are going to require improving training at all research levels. We need to rethink the idea of p-values, null hypothesis significance testing for sure. We need to push towards, stronger study designs when possible. Better long-term education of the public on discourse in science and communication. And then I do think that I found that editors and journals really need to kind of lead in this space. It's not going to happen until we can kind of make our way through. And, there was a wonderful example of like where this can go wrong when, there's a climate scientist who got a paper published in Nature. And what was interesting was he not only published the paper in Nature, but then he published, what he called the full truth of how he got his climate paper published in that high impact journal. And what he left out was as important as what he put in. And he said, if you want to hack a journal, you should adhere to the mainstream narrative, right? He said that, these things were, kind of akin to like what we think right now about climate change and its impact on the environment. And then he said, you got to focus on problems, not solutions, really try to even minimize when improvement exists. And then you've got to like, tell the story in a way where the eye-popping statistics are what you focus on. And, this is very true when I think about like even our own conversations. We try to ground ourselves on like making sure that we don't get like drawn away in these misdirections. And then finally, I'm going to just end with like, starting to ask what I call are the hard questions. And some of these came up last night when I was talking to Dr. Murray too. There's a lot about this, right? Like, so what are the funders and policymakers' role in reform, right? How are they going to, help lead in this space? But then I think a lot these days, I think we all do, who live in the research world, about the role of research in society, right? In fact, we're being asked this directly at this time, and people are raising these issues, right? Like, what's the real value of the tens of thousands of COVID-19 studies that we did, right? There's clearly a lot of remarkable science that happened, but then a lot of this noise as well. questions about democratizing science, is it going to be good or bad? If you put data out there, are you going to have somebody pick one analytical approach or another just to tell the story that they're most interested in? And then finally, I think it's this question about like what should be the fundamental relationship between government and science. And I think that this is such an interesting time because right now, I think we are renegotiating a contract that we made between society and scientists. Back in the 1940s, it's just being reestablished now in ways that are going to change things in the next several decades. What I'll say is that, as journalists, many of you might have seen this recently, but the journals have even gotten now notices from the Department of Justice to ask questions about, well, why did you decide to publish this paper? And why did you decide not to publish this paper? And editorial discretion is a pretty broad thing. And how we try to respond and answer this in a really important way is gonna affect, I think, how much of science starts to get communicated. Now, with all that said, I'm going to end with this last story, which is what I think is a wonderful story. When the New England Journal had its 200th anniversary, they decided that they would do a series of celebration articles. And the first one that they published was by Betsy Nabel and Eugene Braunwald. And they called it A Tale of Coronary Artery Disease and Myocardial Infarction. And what I want to point out with this figure, it's just such an important figure. And I think it's one we could all be proud of as being cardiovascular researchers and clinicians. But if you look, this is basically the number of deaths in the population over time, starting in the 1950s all the way to the early 2010s. And what's fascinating about this is just two things, like the dramatic drop, right? We talked about Dwight Eisenhower's heart attack in the 1950s, but the mortality rate at that time compared to today is just such a remarkable advancement and something I think we can all be very proud of. But it's not only that amazing drop that's really interesting. It's just the slow decline, right? There was no moonshot that suddenly cured heart disease one day. It's just that slow decline over time. It just almost seems like inexorable, right? It's going to happen, and it's just such a remarkable, I think, testament to the value that science has added to our society. And what I love to end with is just this idea that science is not really necessarily about always being right, but it's just about being less wrong over time. So I'll end there, and thank you for the invitation. Dr. Murray, thank you for dinner last night, and really appreciate it.
That was great. Let's open it up for questions. Shinonsa.
Hello, good morning. Hi, Dr. Nallamothu. Thank you very much for the talk. I thought it was very good. What are your thoughts on multiverse analysis to get a wide spectrum of various results based off of several different methodologies and to see which methodology where on that spectrum of results, whether it falls in between or whether it falls as an outlier, as a potential one of many solutions to what we just discussed.
Yeah, no, I think you're hitting on something that's so important, right? These type of multiverse or multiple analysts approaches and stuff are starting to kind of come mainstream. I think in psychology, where there was a real crisis in reproducibility, is where it started. I think it's moved to some of the other social sciences, but I'm 100% in agreement that we need to start adopting these more in the health sciences. I think the concern is sometimes, and I think we're still kind of fumbling our way through making this into simple stories, right? We have to figure out a way to take those complex methods and distill them in a much more strong way of communicating them. So I think it's definitely, it's very exciting. There's a lot of people who are working in this space. I'm hopeful that that's going to be one of the ways in which we'll be able to move forward. I do think that if you are going to take those approaches, I think one of the things that's very important is also just releasing data. And I think we have to figure out ways in which we can, publicly share data in the health spaces. I mean, there are both like regulatory constraints about sharing protected health information data. But what's exciting is there's also new tools now that are coming forward in which we can truly kind of encrypt and de-identify data so that it's very difficult to kind of retro engineer PHI. So
Jake.
Maybe a similar question here, but I wanted you to put your journal editor hat on for a second. As a proud author in your excellent mid-tier journal, one thing I really appreciate is your focus on methodology and rigor. But I will tell you, it takes a lot of time, effort, and money to do the studies that are going to be published in a journal like yours. And then the process of getting something through editorial review takes a long time. It's a slow and expensive process. So as you start to look at where formal journals fit in this process, are we moving towards more democratization where journals have less of a role? Will they always be one part of the solution? How are you thinking about that moving forward?
Yeah, no, Jake, that's a great question. I'll tell you a couple of ways in which I've thought about this. The first is that I think we as journals have to really be much more clear about the value add that we bring. I'd like to think that your process through like let's say CircCQO or another journal, that we gave you good feedback, that it strengthened the paper at the end of the day, and it helped the reporting of the science. I have to admit that at times, even as an author myself, I wonder if that's occurring or the extent to it. So it's a real challenge. I think the other thing that you raised is something I think a lot about, right? Like a few years back when the ischemia trial came out, I was just talking to a friend about this, right? Like the ischemia trial comes out, it gets presented. I believe it got presented at ACC, and then it had a simultaneous publication in the New England Journal. And I was just remarking that like many times, right? Like the ischemia trial investigators didn't need the New England Journal in that case, right? They could have just gone on, YouTube and, just said, hey, this is what, and everyone would have been there to watch it. There's a lot of people who've been talking about when you do have a large federally funded study like that, that you just share the results openly, you have open peer review. So smart people who care about it would comment on it, and then you reiterate on what you would put out as an initial draft. And that's the way in which science should move forward. And that would actually cut out journals. That's an interesting model. And I think that for some types of like studies like ischemia, it could work. I do think that like for a lot of science, though, there is a value add, but we have to kind of come back to what we're bringing to the table. And, I'll just admit, we've tried to shorten and shorten and shorten the time period. But we still have, like, unfortunately, some studies that are very difficult to get reviewers for that are competent. As you mentioned, like sometimes the methodologies are very specific and we don't want to send it out to someone who's going to give a cursory review. It's hard to kind of do that in a way that's rapid. And I live as both an author and as an editor, and there's a great tension to that. There is going to be a lot that changes, though. I mean, anybody that looks at AI and the way that technology is bringing not only for authors, but how reviewers will use that and how editors will use that, I think it's going to be a completely different landscape. I think in my mind, there might even be a model where, like, if you're an audio learner, right, like papers get summarized as a podcast for you, right? If you're more of a visual learner, there'll be a different way in which results can be shared. I think the amount of like change that's going to happen in the next decade is going to be really remarkable.
Rob?
Thanks very much. I enjoyed the talk. I think you just touched on my first question, which was how are we going to use AI in terms of, it seems to me we travel in fairly erudite circles here. We can see two studies published 1 year apart, getting completely different data, and we can rationalize it. But I would go back to my, family and say, who aren't physicians or scientists, say what you think of it. And do you think what we are sort of talking about here is what has caused the current sort of lack of faith in, society and science and in medicine? Because it seems to be growing. And if you can point to something, and say, look, this supports it. Like, how much of where we currently are in terms of the reputation is sort of self-created? And although there's lots of creative things going on, I look at peer review. How many decades, centuries have we been using peer review now? And it seems flawed, because if you can, and I was aware of some of the papers in Nature or Science you had sort of referenced. But if they only get it right 10% of the time, that's and we, again, in this room can sort of say, well, it's iterative, right? We make slow steps, but that's not the way we're presenting it out there. And I'm just sort of wondering, how much has the proliferation of journals, how much has this, emphasis on numbers of manuscripts in terms of promotion and other things, how much have we as a medical community created this problem, and is it good enough to do these small iterations to get out of it? Because I know you say we need to be more open with the data and publish it, but the moment everybody starts doing it, there is not enough time and money to sort of do the type of review. So it's either going to have to be AI, or it just, what'll happen is there'll be a little peak where, stuff gets reviewed, and then we go back to the same sort of situation.
Yeah, no, there's so much in what you were saying that I could talk for a long time about, but I'll get to the core part about our contribution to it. I think for a long time, we haven't forced ourselves to ask these questions, and now we're being asked, probably in the most blunt manner possible. But two examples are, there's certainly a lot that like the COVID-19 experience, I think, taught me, right? One of which was that we too quickly picked a narrative, and I obviously respect everyone's politics here, but I think that just take the lab leak hypothesis, right? How versus it was quickly dismissed as a potential, and who knows? But when you do talk to people outside of us, right, and you talk to people in the community, it's very difficult, because there was this faith and trust, right, that was broken by why was that squashed so immediately, right? And yet, people will use that as a justification for lots of other things now. And I'm just, so struck by, but part of it is that we oftentimes do this ourselves, right? We kind of create one narrative, and we say that that's going to be it. I mean, there's other examples that existed before COVID too. Lots around nutritional epidemiology, right? There's a model in which we say, these are the nutrients that are important for atherosclerosis, and other ones aren't. And we've clearly been, living in a mindset. So how we balance that idea of okay, this is a fair criticism, contrarianism, versus something that's misinformation, right? That's very difficult. And science has always had reversals for that reason. So I think we've definitely contributed to that problem. And then I think about, even from a policy perspective, that's been really important, right? One of the things that, people you guys, I'm sure, are also struggling with, what are indirect rates going to be for funded science, right? This is a question that came up in the Obama administration too. And yet we, as a group, couldn't say, okay, what should it be? What's the logic behind it? How do we set fair rates? And because of that, now it's we're in an environment where it's being forced upon us in a much more direct way. So I think that we need to, just speak openly about some of the things that we talk about on the side, right? Like, why do we have HRRP with like 2 papers in JAMA and we just walk around and we're like, that's what happens, right? I mean, that's ridiculous, right? That's like, you know, if you think about it at a core level, if you had to explain it to your mom would be like, so does it work or does it not work? And why do we have it if it doesn't work, right? And yeah, exactly. So, you know, but if we just sit there and say, oh, well, we're too smart and it could work in some situations and not, no one's going to believe us. So I think we have to really, you know, come to terms. So we have to ask the questions, first of all. And then the second piece is, I think we have to offer some type of solution. If we don't, other people will offer it to us. No.
I think we're going to end it there. Let's thank Dr. Nallamothu for a great talk. Really appreciate it. And let's thank Dr. Murray also for supporting this great effort.